I'm Nazihah from University Kebangsaan Malaysia Medical Centre. I will be the chairperson for today's session. A bit of a housekeeping announcement. This session will be recorded. If you have any questions, you can raise your hand or you can type your questions in the chat box. So our speaker for today is Professor Lawrence Weinberg. He is a Director of Anesthesia at Austin Health, which is a quaternary level university teaching hospital in Melbourne. His clinical research and expertise are focused on anesthesia for cardiac and thoracic surgery, major hepatobiliary and pancreatic surgery, anesthesia for major vascular and abdominal surgery. He has dual appointment as a professor in the Department of Surgery, University of Melbourne, Austin Health, and in the anesthesia perioperative pain medicine unit, Melbourne Medical School, University of Melbourne. Associate Prof Weinberg is proactively committed to improve patient safety, quality and governance of anesthesia service. He has been innovator for delivery of numerous patient and hospital strategic drivers, such as advanced information technology system, new models of anesthesia care, and enhanced recovery after surgery program. Prof Weinberg has been investigator on several large-scale national and international multi-center clinical trials. He also had published 190 articles in international peer-reviewed journal, more than 40 research abstracts, and also had authored a book chapters on pre-intervention, hospital costs after surgery, and acute pain management. He has presented his clinical work and research at more than 100 national and international conferences and academic. He also served as a reviewer for numerous international anesthesia journals and has been investigator for over 35 randomized clinical trials that focus on pre-intervention, patient optimization, goal-directed therapy, post-operative kidney injury, and hospital costs. He also passionate about teaching. He is a student educator, mentor, and coach. He supervises PhD, honors, and medical students, in addition to anesthesia residents and registrar. He conducts regular lectures at the University of Melbourne. Today, his lecture will be on physician-fit therapy for major hepatobiliary surgery, a pragmatic approach using advanced hemodynamic monitoring. Without further ado, I would like to welcome Prof Weinberg to deliver his talk.
Thank you very much, Dr. Nazihah. It's a real privilege to be able to work with you and collaborate with you and your team and to help support the community in anesthesia and critical care medicine, both nationally and certainly in an Australian context. I want to just thank Edward Life Sciences for the opportunity to also present some of our own research and work, and hopefully I'll be giving all of you today a very brief but hopefully a very in-depth overview of precision fluid therapy for major hepatobiliary surgery. These are my conflicts. It's important also to inform everyone that all the images that you will see today, I have received ethical permission and patient consent to use. Everything is de-identified, but Edward Life Sciences nor any other third party or industry have been privy to the content. This content has all been designed and developed by myself and my team. Just to give you a little bit of context, and this is a very important statistic, if a patient comes into hospital in Australia, 1 in 9 patients will have a complication. And more importantly, if that patient requires an overnight stay, in other words, sleeps in the hospital overnight, that complication rate increases to 1 in 4. It's a very, very significant statistic. And our team have done a lot of work at looking at the costs associated with these complications. And before I get into my talk on advanced hemodynamics, I'm going to spend about 1 minute just giving you some context regarding what the implications are, the healthcare burden and costs associated of complications are. We've looked at this very carefully in our pancreatic resection work. We've looked at a 6-year period, and in an Australian hospital, a quaternary hospital where I work, 4 out of 5 patients that are undergoing a Whipple's operation have a complication. It's a very astounding statistic. If you have a complication, clearly you stay in hospital longer. And we also know that the more complications you have, the higher the associated costs of that admission. And if you have more than 4 complications, there's almost a 200% increase in costs. It's not just the number of complications that matter, it's also the severity of those complications. And the more severe your complication is, the higher your cost as well. And again, if you have a grade 4 complication defined by the Clavian-Dido system as organ failure, you have a 228 increase in health costs. If you die, of course, it's much cheaper for the organization. This work with our pancreatic resections has also been shown in our liver resections. We've done the same quality improvement projects. And again, in our liver resection cohort, about 2/3 of patients, 64% of patients that come in for major liver resection are having a complication. And similar to our pancreatic resection work, the higher the severity of that complication, as you can see, the greater those costs. And again, if you have organ failure, almost a 300% increase in costs. So these figures are pretty grim. And these statistics have made us as an organization reflect on how we can better care for patients that we care for undergoing complex major surgery. And this is Austin Health, where I work. And what I want to share with you is some of the strategies that we've put into place with a focus on advanced hemodynamic monitoring, with also a focus on our complex hepatobiliary and pancreatic work, and how we've introduced a program of quality improvement that we think is translating into improving the outcome of patients that we care for. Now, when you're providing anesthesia care for major liver resection surgery, you really have to understand and appreciate the liver anatomy. As we all know, the liver is divided into 8 segments. The right side of the liver is segments 5, 6, 7, and 8. And we know that the right lobe is almost 6 times the size of the left lobe. We know the liver is the second largest organ in the body, responsible for a variety of different functions, from bile production to excretion of bilirubin, to metabolism of fats and proteins, enzyme activation, synthesis of plasma proteins, in particular albumin, and importantly of albumin as well, of clotting factors as well. Now, the first thing that we need to appreciate, or that I look at when our surgeons are booking a liver resection, is what type of resection is the liver resection itself. Is it a minor resection? And we define a minor resection as resecting 3 or less segments. And it's very important to differentiate a minor resection from a major resection, because minor resections have got a much lower association with the development of complications. However, a major resection, as I mentioned earlier, defined as 4 or more segments. So we would call that a right hepatectomy, resecting the whole right lobe, or a left hepatectomy, resecting out the whole of the left lobe, or even more complex resections, such as an extended left hepatectomy, where we remove the left lobe plus parts of the right, or the biggest liver resection that we undertake is an extended right hepatectomy. This renders the patient almost anapatic. We leave 2 lobes, a very, very comorbid and high-risk operation. We also need to appreciate, before we plan how to conduct anesthesia, the basic physiology of the liver, and we know that the liver receives 25% of the cardiac output. We know that 70% of the blood flow enters the liver through the portal vein, and 30% enters through the hepatic artery, which is why, for those of you that are familiar with liver transplantation, as soon as the surgeons ligate or occlude the portal vein, by definition, the patient is anapatic. And if we have problems with the portal vein during surgery, by definition, the patient is in trouble as well, because the majority of blood that flows into the liver is through the portal vein. But it's also important to appreciate that each vessel supplies 50% of the liver's oxygen supply. So although the liver receives more blood from the portal vein and the hepatic artery both supply 50% of blood. And oxygen delivery is dependent on both these critical vessels. The hepatic artery, which importantly is pressure autoregulated. In other words, just like the brain or the kidney, it is very, very well pressure autoregulated. So small changes in blood pressure or in cardiac output won't affect blood flow through the hepatic artery. However, And important to appreciate, the portal vein is not pressure autoregulated, which means that it's very, very prone to systemic hypotension, which of course we measure routinely and usually continuously during all our liver resections. But also it's very vulnerable to changes or decreases in cardiac output. Again, highlighting the importance of monitoring and measuring not just pressure, but also flow through that liver. We also know that the surgical and anesthesia goals during major liver resection are as follows. The surgery is divided essentially into 3 phases, and the anesthesia goals really need to be aligned to these different phases. The first 2 phases, which include mobilization and control of the hepatic inflow and outflow, as well as the stage where they actually resect the liver, the parenchymal or liver resection phase, there is often significant hemodynamic instability, very pronounced, for a variety of different reasons. The surgeons will often retract on the IVC, compromising venous return to the right heart. There's often associated major blood loss from the hepatic veins or from the IVC. And often, as you know, from those of you doing liver resection anesthesia and surgery, when the surgeons occlude the portal vein, we call that the Pringle maneuver, there's also a significant reduction of preload to the right heart, hence a reduction in stroke volume, hence a reduction in the amount of blood getting across the lungs, through the lungs into the left heart. And of course, for more complex resections, where there may be total hepatic vascular occlusion, there is significant problems with venous return from either suprahepatic or infrahepatic vena caval or hepatic pedicle occlusion. And for these patients, we often consider vena-vena bypass or VV ECMO. Now, the use of advanced monitoring, in my opinion, is critical for all major resections. It is now standard of care in the work that we do. Once our first 2 phases are complete, surgeons then have to confirm hemostasis and really close. This is the 3rd phase. And again, the surgical challenges here are to obtain good surgical hemostasis, and they use a variety of different surgical techniques and equipments and sealants to achieve this. Again, in our view, in our hospital, advanced monitoring has a critical role to play in this phase. Now, Dr. Nazihah will outline a Whipple's operation in more detail and cover some of the advanced monitoring challenges with a Whipple's operation, but a Whipple's operation or a pancreaticoduodenectomy is a very different operation to a liver resection. We know that generally these patients will have a tumor in the head of the pancreas, not the body or the tail. That's a different operation, either a central or a distal pancreatectomy, with or without a splenectomy. But for a Whipple's operation, essentially by removing the head of the pancreas, there's 3 main anastomoses or joins. The rejoining of the bile duct to the liver, which reestablishes bile flow from the liver into the bile, the pancreaticoduodenostomy, which again joins the pancreatic remnant or the rest of the pancreas again to the bowel to ensure that there's flow of pancreatic juices. And then the gastrojejunostomy, which really allows passage of food from the stomach to come through into the rest of the bowel. Now, this is a case that I did just 2 weeks ago of a Whipple's operation, and you can appreciate how over 3-4 hours of anesthesia, how stable anesthesia often is for a Whipple's operation. Often it isn't, but sometimes it's very, very stable anesthesia. And if you have a look and appreciate how stable my blood pressure is, it's equally as important to appreciate that just because you have normal blood pressure, it doesn't mean your patient is healthy. You can have a completely normal blood pressure with either a very high cardiac output, a very low cardiac output, even a normal cardiac output, depending what your systemic vascular resistance is. So the lessons there, or the principles, is just because your patient has a normal blood pressure, it doesn't mean they're healthy. Reiterating the importance of advanced monitoring, not just for liver resection work, but also for major pancreatic resection work. So how have we embraced advanced monitors at our hospital in Melbourne, Australia? And I'd like to give you this information to allow you to see this through a slightly different lens and really to empower you, to allow you to appreciate that hemodynamics really does not need to be confusing. And even for major liver resection, which is applicable to all major operations, the monitors that we use, advanced monitoring devices, are diagnostic and hemodynamic monitoring tools. These devices are not therapeutic interventions. These devices allow us to treat patients more effectively. They provide us with information that helps us to differentiate and determine what component of that patient's hemodynamic profile needs to be adjusted or readjusted to reestablish what's normal for the patient. And during major liver resection surgery, there really are 6 common hemodynamic states. And if you can appreciate these common hemodynamic states and apply these not only for patients undergoing major liver resection surgery, this will really empower you to take much better care of patients really having any type of complex operation. As you can see in the video, this is a very complex right hepatectomy here. And during all major resections, let's understand what these hemodynamic states are. Firstly, we have to understand what normal is. Now, clearly, from the pressure-based metrics, you can see this patient clearly is not normal. They're profoundly hypotensive. But it's important to appreciate that normal is your first hemodynamic state. The next most common hemodynamic state during major liver resection and pancreatic surgery, in my, again, view, is hypovolemia. But importantly, the third and fourth hemodynamic state is to differentiate if that hypovolemia is absolute, in other words, the patient is losing volume or fluid, or whether it's just a relative hypovolemic state from the venodilatory effects of the anesthesia drugs that we use. And I'll expand on that in more detail. The fifth very common hemodynamic state is, of course, vasoplegia or low systemic vascular resistance. And then importantly, cardiogenic. And for those experienced in advanced hemodynamic monitoring, we do run a more advanced course where we break down the cardiogenic component into heart failure with a reduced ejection fraction, the old nomenclature, which is LV systolic failure, heart failure with a preserved ejection fraction. This is the new terminology for LV or left ventricular diastolic failure, right ventricular failure, again, a very different pathophysiological entity to left-sided heart failure, and of course, biventricular failure. So how do I set up my advanced monitoring and how do I approach my anesthesia for major liver resections? Well, firstly and importantly, and this is all able to be achieved on the advanced hemodynamic platforms that we use at Austin Health. We do use the Edward Life Science Hemisphere platform, as well as the EV1000 platform. But it's more important to use any platform that gives you the information to allow you to make more informed decisions. So whether it's the Edwards platform or any other platform, it's the information that you need that allows you to make those more informed decisions. But the first parameter that I do individualize for the patient is what mean arterial pressure do I want to defend? And generally, I'm very comfortable defending a mean arterial pressure of 65 or above. Now, of course, if my patient's got underlying hypertension or has underlying carotid disease or has had previous TIAs or cerebral vascular disease, I may choose to increase that mean arterial pressure that I'd like to defend throughout the operation. Once I've decided on what mean arterial pressure to defend, again, for major liver resections, I also like to ensure that my stroke volume, a very important metric of contractility, is normal. And we know that a normal stroke volume is approximately 1 to 1.5 mils per kilo per beat. Very important to evaluate this information either prior to anesthesia during your preoperative assessment, or if patients have had previous cardiac investigations, to have a look at their ventricular function and ascertain what is a normal stroke volume for this patient. Now, for major liver resection surgery, I also adjust my stroke volume variation, the metric for or trigger for volume responsiveness. And for the first two phases, the stage of surgical resection and of resection of that liver lesion, I usually would accept a much more restrictive anesthetic SVV trigger than a more liberal one, because it does help the surgeons and does help keep my central venous pressure low. So for the first two phases of a liver resection, I would keep my stroke volume variation trigger at 25. But again, once the resection has been complete, I will catch up on that fluid intervention and readjust my stroke volume variation trigger back to normal and accept a stroke volume variation threshold of 15%, which is really conventional and aligned with most of the textbooks as being normal. I also do think it's important to measure central venous pressure, either to enter it indirectly, or to slave it directly off the monitor so it can calculate your systemic vascular resistance, which also is very informative. And this is what I call a patient-specific, surgery-specific, or individualized care protocol, because complex decision-making really cannot be left to guidelines and algorithms alone. We have to individualize our anesthesia goals for our specific patients, precision anesthesia. Now, on the platform that you're using, and I've used the Hemisphere platform, in the settings menu, it's important, and I find it really, really valuable to go into that settings menu and find the global positioning screen or the GPS screen, which looks like the screen that's in front of you. And I set my stroke volume responsive trigger on my y-axis, which again depends on the phase of liver resection that the patient is in. And as you can see here, I've set it between 13 and 27. I've set it at 25. But then on my x-axis, I set what I think is a normal stroke volume or a normal cardiac index for that patient. And if a patient is in the zone which is green as displayed in front of you, in other words, has a stroke volume variation that's less than the threshold that you set and has got a normal stroke volume for that given patient, this is what I call the patient's ideal zone or patient's individualized zone. Finally, I do set my time scale. And here you can see I set it at 1 minute, which means that every 1 minute the machine will give me a trend as to what is happening over a 6-minute period. Now, once you've got this set up, it's very, very easy for you to understand the 6 hemodynamic states. Because if your patient moves to the bottom left-hand corner of the screen, in other words, their cardiac output falls, but remains below that stroke volume variation trigger, clearly the patient is not volume responsive and has got a low cardiac index state or a low stroke volume, so this must be a cardiogenic problem. This is a very, and by the way, there's also very, very interesting and emerging technology that better allows you to understand that cardiogenic state. We're now using what's called dP over dt, which is another metric slaved off the arterial waveform that allows us to better assess left ventricular contractility. Now, if the patient moves to the right-hand bottom corner of the screen, in other words, a high cardiac output, but still volume unresponsive, this patient really has to be vasoplegic. It's not possible to have a high cardiac output in the context of a low blood pressure unless your systemic vascular resistance is low. This is a very easy phase to recognize and a very, very easy phase to treat. If the patient is vasoplegic, then we have to use a vasopressor to normalize a low blood pressure. And it doesn't matter what vasopressor you choose to use, whether that is aramine or phenylephrine, or if refractory to those two, to introduce low-dose noradrenaline, or vasopressin if it's even more refractory, or methylene blue or angiotensin 2. The principles are that a low systemic vascular resistance state need a vasopressor to support the circulation. The third state is really a combination, top right-hand corner of the screen. These patients are fluid responsive, but they're also vasoplegic. You will never see the state, or very seldom see the state, in a major liver resection or major pancreatic resection. This is more common in early sepsis, when patients come in needing to be fluid resuscitated and have their early sepsis controlled. We occasionally see this during complex liver transplantation. But these two final states, these fluid responsive states, this is the fluid responsive zone. You're above that SVV trigger, so you're fluid responsive, either with a normal cardiac output or with a low cardiac output. Absolute or relative fluid responsive states. Now, let's just segue and appreciate that there's emerging work, really compelling work, that has allowed us to better understand that just because you're fluid responsive, it doesn't mean that you will increase your blood pressure in response to that fluid. So fluid responsiveness doesn't always mean pressure responsiveness. And for that reason, we also now are using more advanced hemodynamic metrics, such as dynamic elastance, to help us better differentiate those patients that are fluid responsive as to which of those patients will also be pressure responsive. And this is really exciting and emerging technology, also available on the Edward Life Sciences platform. And essentially, and very briefly, effective or dynamic arterial elastance is really that interaction between the large vessels and ventricular contractility, the ratio between pulse pressure variation and stroke volume variation, and really a functional assessment of afterload. And as I mentioned to you earlier, it helps us differentiate which preload responsive patients will increase their arterial pressure in response to fluid administration. And we think now a EA dyne of greater than 1.2 or 1.4 will help us differentiate whether fluid will increase both stroke volume, but also increase mean arterial pressure. Very different to an EA dyne of less than 1. And here, as you can see, an EA dyne of 0.8 will tell me that even if that patient is fluid responsive, they're unlikely to increase their blood pressure in response to that fluid. And this is a very useful metric that we better understanding and doing some interesting research with, because it allows us to, one, initiate vasopressure support, but also titrate that vasopressure support as well. Fluid volume or fluid boluses here still are important for delivering flow, but they won't necessarily increase your mean arterial pressure. And really what I've given you now is a very simple but very robust overview of approaching advanced hemodynamics for major liver resection and major pancreatic resections. In addition to the metrics that I've mentioned to you, we also know that the hypertension prediction index technology is now emerging really throughout the world. And this is now technology that allows machine learning to predict which patients will become hypotensive well before the clinician can even predict when that patient will start becoming hypotensive. Really exciting technology, and Dr. Nazihah hopefully will also allude to this in her presentation. And this is the example of the HPI prediction index screen, which gives you a very comprehensive overview of incorporating now predicting which patients will become hypotensive, instead of being more reactive and treating hypertension once it emerges, to allow us to more proactively prevent it from happening. So in summary, putting it all together, for major complex liver resection, we have to not only look after the macrocirculation, but we have to look after the microcirculation as well, and use the microcirculation to inform us that the macrocirculation is healthy. Unfortunately, they're very crude metrics of measuring the microcirculation in the operating room or in the intensive care unit. Of course, we use lactate or base deficit, but they're very crude metrics of ensuring that the microcirculation is healthy. There are more novel emerging metrics that we use for research: urinary oxygen tension, gastric pH, mixed venous oxygen saturation, and others, but really not really applicable for anesthesia for major hepatobiliary surgery. But in terms of the macrocirculation, this is the algorithm that our hospital uses. We ask two questions. Is my patient stable? Is the macrocirculation stable? Because if they're stable, we shouldn't do anything. But if they're unstable, we ask three additional questions. Is this patient hypotensive? We don't treat, we ask the question. Because if they're hypotensive, we then ask, are they preload responsive? Because a hypotensive and preload responsive patient really either has an absolute hypovolemic state, which we need to treat with fluids because they're losing fluids, or a relative hypovolemic state. This is a venodilatation state, which we are cautious with not treating with fluid because there is no fluid loss. It's all relative, and we treat this with a vasopressor. As I mentioned to you, dynamic elastance is a really helpful metric here to determine which of these patients will further benefit from fluid intervention or will need fluid intervention, or which patients, even though they're volume responsive, will not be pressure responsive. And in these patients, you really have to go back and look at contractility and look at cardiac output. Because if your pressure unresponsive patient is hypotensive or your pressure responsive patient is not pressure responsive, then if your cardiac output is high or if your DP over DT is normal or high, it's a very different intervention as to if your cardiac output or your cardiac index or your stroke volume is low, also reflected by a low DP over DT. A high cardiac output in the context of a pressure unresponsive patient must have a low SVR. And of course, as I mentioned to you, we must go down the vasopressor road. But if your patient is hypotensive, preload unresponsive, and has got a low cardiac output or has got a problem with contractility, you have to think about the heart. I was really pleased to read the most updated review on the benefits of goal-directed therapy, a 20-year systematic review published in Critical Care. And the conclusion of this review was goal-directed therapy doesn't cause harm. In this review, again, I think a very contemporary and up-to-date review, irrespective of the amount of fluid administered, goal-directed strategies reduce complications. Of course, these studies are small, are limited, they're unable to show an impact on mortality, but certainly we can see here a strong signal into preventing and minimizing postoperative complications. And I was really quite proud when two of our studies used that we undertook at Austin Health again contributed to this systematic review done by Messina et al. And certainly would commend this. So in summary, anesthesia for major hepatobiliary and pancreatic surgery, we have to individualize care. Advanced hemodynamic monitoring allows us to make much more informed decisions. It empowers us as clinicians. Hypertension is always pathological. We need to understand why these patients are hypertensive and implement the correct strategies. But normotension doesn't imply our patient is healthy. So again, for these complex operations, we need more than pressure metrics. We need to look at flow-based metrics as well. Really, I hope I've empowered you to master the 6 basic hemodynamic states. I learned these from Professor Colin Royce, one of the doyens of major anesthesia in Australia. And really, him and his team have allowed us to fine-tune how we approach these basic states. And hopefully I've enabled you and given you a very, very simple but very good overview of approaching these 6 hemodynamic states. Remember, as I said, fluid responsiveness doesn't mean pressure responsiveness. And let's try and move towards dynamic precision, physiologically informed resuscitation and optimization. So with that, I thank you. Just a few minutes over. Thank you, Dr. Nazihah, for allowing me to give you an overview of how we approach advanced hemodynamics at our hospital. And I look forward to hearing your presentation and then hopefully to apply some of the clinical applications in the next presentation that I do. So thank you again.
Thank you very much, Prof Weinberg. If the participant has any questions, you can raise your hand now and we will unmute you. Or, okay, we have one question. from Jaffa and also Lashmi Kumar. So can we unmute Jaffa first?
Yeah, yeah. I'm audible.
Okay, Jaffa, you can proceed with your questions.
Yeah, in post hepatectomy state, the lactate will be usually higher. So how can we manage how to differentiate whether it is due to low perfusion or is it due to the hepatectomy change, and how to manage the fluid?
Wonderful question, Jaffa. Thank you very much. And that's a very, very thoughtful question. So first of all, I think we need to have a very good approach to hyperlactatemia, particularly during post-hepatic resection. And as you know, and as our listeners will appreciate, there's two types of lactic hyperlactatemic states. There's type A and there's type B. Now, type A is really important because type A is a consequence of low flow states, of tissue hyperperfusion, where the body generates lactate as part of using energy because of a compromise in the microcirculation. And that's a really important situation to avoid. But we also know that there's what's called type 2 hyperlactatemia or type 2 lactic acidemia or lactic acidosis, very clearly defined by Woods and Cohn many, many years ago. And patients may have very high lactate levels, even in the context of normal flow. We see this in our liver transplant patients, and there's three reasons for this. First is patients may have problems with the liver themselves, with the liver itself. And as we know, the liver is the main organ that metabolizes lactate. So if the liver's not working, hyperlactatemic states are very common. We see this commonly in our liver transplant patients, and for those reasons, we choose not to use Hartmann's solution, which is a lactated Ringer solutions for our complex liver resection cases, because the lactate in the Hartmann's can't get metabolized and gives you a very artificial state. We also know that if you have very sick patients, patients that are septic, these patients also can't metabolize lactate effectively. It's very, very common in septic high flow states, and very rarely we have patients that have got problems with pyruvate dehydrogenase that can't metabolize lactate. So in the context of liver resection surgery, two things to bear in mind. Our rising lactate level is certainly concerning because it either means that the liver that is not being resected is hyperperfused and not functioning well. And this is a very, very significant problem because post-hepatic liver failure is associated with almost a 70 to 80% mortality. So a rising lactate level for major liver resections is very, very concerning. It's also important for us to try ensure that we don't cause a type 1 lactic acidosis because of hyperperfusing states. And in my opinion, advanced monitoring again allows us to better ensure that not only is pressure being maintained, but also flow is being maintained as well. So your point in summary is really important. A high lactate level may be associated with post-hepatic insufficiency. And certainly during surgery, I do look at my lactate as a metric of, is my liver happy? Is my liver healthy? And is the residual liver coping well? Because if the lactate is rising, I'm very concerned about a risk of post-hepatic insufficiency. And we use advanced monitoring for all these patients. And if the lactate level continues to elevate with advanced monitoring, I'll insert a transesophageal echo probe to further ensure that I'm really optimizing my macrocirculation. So thank you for that comment, and a very, very interesting point that you've made, and a very important point for major hepatic surgery.
Thank you, Prof.
Thank you. Thank you. Thank you.
We have one more questions. I will allow one more questions from Dr. Lashmi. Dr. Lashmi, you can ask your question now.
Yeah, I'm sorry if I'm taking up time, but Dr. Weinberg, this is something you did mention that you would like to keep the stroke volume variation on the highest side at the time of hepatic transection. Yet, at the time of liver resection, surgeon partially clamping the IVC can suddenly change an SVV of what was 12 to 25. So how accurate are we when they are manipulating the IVC and the liver to say we are fluid restricting and I've kept the SVV at 25? Are we right always? Because surgical manipulation alters the SVV tremendously.
Absolutely, and what a very good point, Dr. Kumar. You're quite correct. SVV is really just a metric of volume responsiveness. In other words, of preload, of an impact on preload to the right heart. So if that preload is reduced because of surgical bleeding, or because of high urine output, or because of the surgeons occluding blood back to the right heart, the patient will have a high stroke volume variation. Absolutely. And in that situation, we need to support the circulation, because during a Pringle maneuver, or as you know, often during liver transplantation, when they do occlude the IVC, we do have to cope with a reduced preload state. It's a very difficult preload state to manage, because often during this state, you do have to support circulation with a vasopressor, knowing that it's short term, it's temporary, and flow will be restored. Often for our major resections, though, even in the absence of severe Pringle maneuvers, or if the surgeons are occluding hepatic outflow or flow back to the right heart, we do now look at both CVP and SVV as a metric of being more restrictive. But being more restrictive doesn't mean that we should tolerate hypovolemia. Hypovolemia is always deleterious, but being restrictive in our fluid intervention for that specific phase of the surgery, we think is safe, provided you're still maintaining a perfusion pressure as well. But if you've got a reduction in preload and you're hypotensive, you really have got poor blood flow to the liver that's going to be remaining, the remnant liver, in addition to hypotension and compromise to the microcirculation. So very, very difficult and challenging situations, which again reinforces the need to measure volume responsiveness, but not just measure volume responsiveness, have a look at the impact on that on stroke volume, on cardiac index, and of course on mean arterial pressure, or on systemic blood pressure.
Okay,
Thank you.
Thank you, Dr. Ashmi, and thank you, Prof, for your explanation. I think this is a very, very comprehensive and very excellent lecture. Thank you very much for your new knowledge. So we will move to next session of this today's session. I will discuss regarding the pancreatectomy case. Can you see the slides? Okay. So today I will discuss a pancreatectomy case monitored using Acumen IQ, in minimally invasive hemodynamic monitoring with hypotension prediction index software. This is a simplified version of case discussion, whereby I will just highlight a few events for discussion. This patient is a 72-year-old male with a height of 170 centimeter and weight of 70 kilogram. He underwent pancreatectomy for malignant neoplasm of the pancreas. He has underlying history of hypertension and ischemic heart disease on bisoprolol, Twinstar, and also aspirin. So an outline was inserted prior to induction. On your right, you can see the basic hemodynamic monitoring, which is your blood pressure, heart rate, and also SpO2. And on your right is your my hemisphere interface, which shows as SVV, SV, MAP, DPDT, and also SVR. He has a fairly normal blood pressure preoperatively with a BP of 120/61 with MAP of 86 with a heart rate of 73. Patient was then induced with fentanyl 100 mg, propofol 80 mg in titrated dose, and rocuronium 60 mg. He was then intubated and connected to the ventilator. 5 minutes post-induction, the HPI alert pop up with the HPI value of 92. The blood pressure at that point was 96/51 with the MAP of 69. Heart rate was 86. At this point, the advanced hemodynamic monitoring shows SVV of 11 with cardiac index of 1.8 and DPDT of 591. So as we can see, the HPI increased more than 85, in which it is predicted that the patient will have hypotension within few minutes time, and the MAP also dropped from 85 to 69. Are you concerned regarding this event? You can go to the chat and you can respond either yes or no at the chat. There's only 2 responses so far. All right. Okay. Most of the response shows they are concerned about this post-induction changes. So as you can see here, the new parameters that has been bring by Acumen IQ and Hemosphere is DPDT, which is surrogate the contractility of the left ventricle, as what has been explained by Prof Weinberg before. Okay. So here we can see that post-induction, the DPDT actually dropped from the baseline. So it is a maximal upslope of the arterial pressure waveform from a peripheral artery, and it is estimation of the left ventricular contractility. So what action plan would likely help? Either to give the patient a fluids 100 to 150 mL, or give start IVI at noradrenaline, give ephedrine bolus, or you can just observe. You can pick the response from the chat box. Okay, so there's a few response there. Some want to give a fluid bolus, some wants to start IVI noradrenaline, and most of them want to give an ephedrine bolus. So what I do was I actually gave this patient a bolus of ephedrine, 6 milligram. The reason being is because it is quite expected that the anesthetic agents has some myocardial depression properties. So ephedrine, which is a sympathomimetic drugs, can actually reverse the action. So as we can see here, when the HPI increase, the MAP start to decrease. And at this point, before the MAP really come down below 65, we already intervene with ephedrine 6 milligram bolus. And the HPI start to drop again, and our MAP increase back again. And the DPDT post-ephedrine actually increased back to almost a baseline value. So another event occur maybe half an hour following that. The HPI alert more than 85. At this point, the BP was 93/57 with MAP of 72. The heart rate is 62. The other parameter shows SVV of 24 with iodine of 1.3. So I hope we all listened to Prof Weinberg talk just now. Iodine 1.3 shows that the patient is fluid responsive, and fluid administration will increase the stroke volume and also increase the MAP. So what would be your treatment of choice? Either fluids only, or you want to give fluids with vasopressor, or you want to give vasopressor, inotropic, or fluid with inotropic. Okay, this is getting interesting. Okay, so basically, for this case, I actually gave the patient with a fluid bolus of 250 mL. The reason being is because the SVV is way too high for me to be too restrictive. And following the 250 mL of fluid bolus, we can see that the SVV improving, but not only the SVV improving, but the DPDT also improve, because your contractility is also depend on your preload. So once you improve your preload, your contractility also improve. Okay, So for the next event, at this point, the MEP is still okay with the blood pressure of 104/51 with MEP of 72, heart rate is 73. The HPI pop up again with the HPI alert more than 85. With the SVV value, sorry, it's a bit small here, 25, and also the SVR value of 1057. Okay, I don't have a poll for these questions. For this event, I actually gave the patient a fluid bolus and a stat dose of phenylephrine, which is a vasoconstrictor. Okay, with this intervention, the SVV and also the SVR improve back. Okay, so in summary, while doing this case, there are about 15 events of HPI more than 85. Okay, in which every episode of HPI more than 85, we look for a cause and we intervene before the MAP really deep down below 65. And as you can see here, the hemisphere interface, it has an advanced parameters arranged by preload, contractility, and afterload, and allow opportunity to investigate and identify the root cause of potentially developing hypotension. We do not treat the HPI as a sole number, but we use the HPI as an alert for us to act and to treat the possible causes. So for this case, the surgery and anesthesia time about 301 minutes. I only have one event of hypotension, which is less than 1 minute actually, with the lowest MAP about 63. There are no event of severe hypotension in this case. And post-operatively, he was extubated and monitored well in our post-anesthesia care unit. And all the post-operative blood investigations such as renal profile and cardiac enzymes were within normal range. And patient was discharged home after post-op day 4. So in summary, the intraoperative hypotension is really common and harmful. It has shown that intraoperative hypotension increases the risk of mortality, risk of acute kidney injury, and also myocardial injury. And the risk of organ injury increased with the increased depth and duration of the MAP below 65. With that, I end my presentation. Thank you. So before we went for a question session, I would like to invite Prof Lawrence to share your case discussion.
Thank you, Dr. Nazihah. What a wonderful presentation and a really important, just really important reflections on how you approached that case and how the additional information, in my view, just gave you or any other clinician just additional information to really help you care for that patient. Congratulations, really a wonderful overview of how to apply advanced monitoring in the context of high-risk surgery. So congratulations. I'll see if I can share my screen. And is that able to be seen by everyone?
Yes, Prof.
Okay, wonderful. So look, I'm just going to follow through on Dr. Nazihah's presentation and again, spend about 10 or 12 minutes giving you an overview of how we apply the advanced monitoring for patients undergoing major resection with a focus on the liver. Not all these cases will be extended right hepatectomies because I've taken the pearls of a variety of different cases that I've looked after and really will try build on the information that I've given you at the beginning, the approach, the 6 hemodynamic states, and really help you apply these in your everyday practice and allow you to demonstrate how easy they are to really apply. So for major hepatic resection, we've moved away from epidural analgesia and anesthesia, mainly because of the risk of postoperative coagulopathy. We know from work that we've done and from work from other researchers that after major resection, the liver does become slightly compromised because the liver is that organ that is responsible for the synthesis of plasma proteins and all our clotting factors. So for those reasons, we've moved away from indwelling neuraxial catheters and we've moved towards single shot spinal analgesia. And this is an extended right hepatectomy that I undertook. There were no contraindications to spinal analgesia and anesthesia. And my technique generally for single shot spinal analgesia and anesthesia is using a combination of heavy bupivacaine, a small dose of clonidine, usually half a mic to 1 mic per kilo, and we use intrathecal morphine again just for improving our post-analgesic outcomes. Again, work that we've looked at, and we think it certainly confers good analgesic outcomes for our patients. So this is at about 9 o'clock in the morning, and my spinal, and that is the spinal that I've done, has gone in very well. But 10 minutes post the spinal, I'd like to now share with you the hemodynamic screen that's present. A nice slow heart rate, very in keeping with a high spinal. Often with a high spinal, you block your cardiac accelerator fibers, so you can't generate a very high heart rate. And we also know with a high spinal, sometimes it can affect contractility. Spinal analgesia causes vena and vasodilatation, and I was left with a situation of how do we manage the situation? And I think you'd have to be a very, very smart and experienced anesthetist and perhaps have a bit of good luck to be able to decide what the hemodynamic state is without having any further information. Because I don't think it's possible to make the correct decision or an informed decision based on just this pressure-based information alone. And as we can see, and as Dr. Nazihah presented as well, we can see that over a 6-minute period, and I've used my global positioning screen here, the cardiac output has fallen to the bottom left-hand corner. The patient is volume unresponsive. I've set my SVV trigger at 25 again, or 20, which I commonly set for my first 2 phases, and appreciate how that cardiac index really has gone from 3.5 all the way down to 1. If we look at this differently, again, you can see this is 9:15 in the morning, really 10 minutes after that spinal, after I'd instrumented the airway and the patient is positively pressure ventilated, a significant fall in cardiac index and stroke volume together with a profoundly abnormal blood pressure. This is clearly a very simple state to recognize. This is a cardiogenic problem. And like Dr. Nazihah advocated earlier, my choice of a inotrope is ephedrine. Ephedrine is a wonderful inotrope in the context of anesthesia. Most of ephedrine, 80%, is beta-1 and beta-2 in its effects. It's also got a small amount of alpha-1 activity. So 20% of ephedrine behaves like aramine or low-dose phenylephrine, but the majority of ephedrine really helps contractility and helps chronotropy. And as we can see at 9:20 now, we've gone from a very, very profoundly hypertensive state, and we've normalized the macrocirculation, following the simple principles of the 6 abnormal hemodynamic states back into the ideal zone. What I've outlined here is post-spinal, an example of a cardiogenic problem, very easy to identify and appreciate with advanced monitoring. And as Dr. Nazihah mentioned as well, additional parameters such as DP over DT can be used. This is a case of an extended left hepatectomy. All these pictures I've taken myself. These are of the real cases. We're 1 hour into the case now, no surgical bleeding. Again, I've offered this patient a single shot spinal analgesic anesthetic intervention, same combination of bupivacaine, clonidine, and intrathecal morphine. And again, 1 hour into the case, we've now got profound hypotension. We're running a 1.3% sevoflurane. We've got a nice normal end-tidal CO2. Obviously flushing a drug in because this patient is profoundly hypotensive. We've got a PPV on the screen of 13 and a nice slow heart rate. Very difficult to understand what the hemodynamic state is. But let's introduce some advanced monitoring now. And we can see in the context of profound hypotension, we've got a patient who's got a very high cardiac index, essentially volume unresponsive with an SVV of 12, with a stroke volume index, again, that hasn't changed much, but really on the normal side. So in summary, we've got a hypotensive patient who's volume unresponsive, who's got a high or a normal to high cardiac index. And again, my treatment clearly is to address that of one of vasoplegia. And here I'm using aramine. It's dilute aramine. This patient clearly is in a vasoplegic zone, bottom right-hand corner of the screen, identifying, again, a common hemodynamic state based on vasoplegia. Let's talk a little bit about central hepatectomy, case number 3. And this is a central hepatectomy where the surgeons unfortunately ran into a complication of a tear in the inferior vena cava. Now, as was mentioned earlier by one of our delegates that kindly commented, despite it being extremely uncommon, post-hepatectomy liver failure is a dreadful complication following extended hepatectomy or following what we call a liver trisectionectomy, a trisegmentectomy. It's also been reported in up to 12% of patients having extended right or left hepatectomies, particularly those patients that have got underlying chronic liver disease, patients that have got underlying fatty disease, or in patients that have received long-term chemotherapy. And a central hepatectomy is slightly different to a right or a left hepatectomy because it defines an anatomical block resection of the segments 4, 5, and 8. And it's a really important operation to do because it preserves more liver. So in patients that won't tolerate an extended right or an extended left hepatectomy, in centers of excellence, if the surgeons are skilled enough, they can just wedge out the central part of that liver, segments 4, 5, and 8, to preserve as much functional liver parenchyma as possible. And as you can see, with a tear in the IVC, we're in a situation that is concerning. There's already a liter of blood in the cell saver, and the question is, what's my correct intervention? But here you can see a patient that is mildly hypotensive, and it's important to recognize that in the context of major hemorrhage, as you've just seen, you often are unable to mount a tachycardia. And in fact, even in the context of major bleeding, your blood pressure often changes very, very late, reiterating the importance of devices like the hypertension prediction index that predict when these events are likely to happen rather than them happening and you reacting to them when harm has already been caused. So here we can see a hypotensive patient, and let's move on to our advanced monitoring devices. And clearly we can appreciate here that over a 72-minute period, I've really probably lost a bit of focus here and failed to appreciate that over 72 minutes, my time here is 12 minutes, my patient has become more and more and more volume responsive. And clearly in the context of bleeding, the intervention is fairly clear. This is a volume responsive patient. And in my opinion, and let's have a look at what my intervention was here, but in my view, this patient definitely needs aggressive volume resuscitation. And that's exactly what I'm doing. And in response to that volume resuscitation, we should appreciate as the preload is increased, as there's more fluid that returns to the right heart, we can already see how that volume responsive high range is coming down. It was 25 to start with, and we can see now how it's coming down to 17. And as that patient continues to stabilize, we will normalize the patient's normal hemodynamic variables. As I mentioned earlier, I think it's a strength to call a friend or call a colleague or to escalate the level of monitoring if you're unsure of what the hemodynamic state is, because a flow track device or a esophageal Doppler or a Pulsion device won't inform you whether this patient has got cardiac tamponade or has got a significant valvular problem with the heart. And occasionally I do escalate my monitoring. I've put a transesophageal echo probe down and we can see the left ventricle, the papillary muscles, anterolateral and posterior medial really kissing each other, kissing papillary muscle sign, a very undervolumed hyperdynamic ventricle, reinforcing that I'd fallen too far behind on fluids. And what I've demonstrated here is a volume responsive state. This is absolute volume responsiveness from blood loss. As I mentioned earlier, it's important to break down hypovolemia into absolute, which can be non-hemorrhagic from insensible losses or urine losses, but also hemorrhagic from bleeding, commonly in our crafts. But hypovolemia can also be relative, as I mentioned, from increased venous capacitance or decreased elastance, common during anesthesia, SIRS, sepsis, inflammation, or medications. This case number 4 is a very high risk liver resection, segment 8, segment 7. So not by definition a major resection, but in a patient with very advanced cirrhotic liver disease. And have a look at how cirrhotic, how nodular that liver is. No surgical bleeding, and we are now 3.5 hours into the operation. And again, have a look over 30 minutes how my patient has progressively become more hypotensive. Now, this was before I was using hypertension prediction index. This would not happen in our current setup because the HPI system would allow us to predict much more early, much more aggressively which patients will become hypotensive. But I want you to appreciate what happens when we treat this volume responsive state with a venopressor. Now we can see here, as I mentioned earlier, that our SVV is 20, so we're volume responsive. We've got a low cardiac index, but have a look at what happens as I use a venopressor, and all the vasoactive drugs will venopress. So now instead of using fluid, I'm venopressing, I'm increasing or squeezing blood from the splanchnic vessels back to the right heart. And as the blood returns to the right heart, my preload increases. As my preload increases, you can appreciate now how my stroke volume variation decreases. And that increasing preload is really enjoyed by the left heart because more blood gets to the left heart. And you can see that my stroke volume, my cardiac index, hence my blood pressure has improved. This is an example of a relatively fluid responsive state. Now, remember when I said pressure doesn't equal flow. And this is an example of a patient where I've used too much vasopressor. And I want you to have a look at what happens when you've got a hypotensive patient. We've got a very, very good cardiac output, good contractility here, cardiac index of 4.1, a normal stroke volume index. But again, I've used a vasopressor, perhaps in a slightly higher dose. I've bolused 20 mics of noradrenaline, and we can see that profound increase in blood pressure. But more importantly, I want you to appreciate as that blood pressure increases, sometimes the increase in afterload really makes that left ventricle struggle. And instead of increasing flow, we actually often compromise flow. And here you can see a wonderful example of normalizing blood pressure, but you can appreciate how that cardiac index and that stroke volume has been compromised. And we know that if you have a preload dependent patient, phenylephrine or metaraminol, as I mentioned to you, will increase preload, therefore increase cardiac output. But as demonstrated by this case, when you have a preload unresponsive patient, you need to be very cautious with how you use vasopressors, which is why advanced monitoring again is helpful, because as you can see from this additional case, we've gone from an SVI of 2,000 to 3,600. And whilst we've normalized blood pressure, we've also compromised flow. We've reduced our cardiac index from 3.5 to 1.7. So in summary, for our major liver resections, and this has already been asked by one of our audiences attending, we can see at the start of major liver resections, we've got normal parameters. During that resection and dissection phase, I do allow the SVV to drift, but we should ensure that our patients don't become hypovolemic. Hypovolemia is deleterious. So whilst we can accept a volume restricted state, high SVV anesthesia or low CVP anesthesia, we shouldn't allow the patient to be hypotensive. And as you can see, I've generally defended cardiac index and defended stroke volume. And at the end of the case, I've increased my volume resuscitation and normalized that patient's hemodynamic state. And there's that cirrhotic liver that we've just removed from that case. This is a small trick that I often use if surgeons would like a low CVP anesthetic. I'm sure this is something that you've maybe used in your own practice. You can apply this to any patient, any surgeon, and any liver resection. This is Professor Murali Hadran, who's a good colleague and friend of mine. And I want to show you the CVP trick that I use when the surgeons demand a low CVP, but I'm uncomfortable running the patient too restrictively. So we've got a lovely normal blood pressure, but have a look at my CVP, it's -2, and the surgeon is very thankful and very grateful. Why is the CVP low? Because I've increased the height of my CVP transducer to keep the surgeon happy, but not to compromise flow, because being too restrictive is also deleterious. I've now normalized it just to demonstrate how that CVP has now normalized. It's just a trick that I tease the surgeons with, but they know that I'm playing a joke on them most of the time, and now they peek over the Drake to ensure that the transducer height is normal. And that's the tumor that has been removed. So again, in summary, hopefully I've allowed you to appreciate some clinical applications of how I apply advanced monitoring, particularly in the context of major liver resection surgery. And I think we've had a wonderful overview by Dr. Nazihah about how to apply advanced monitoring for patients undergoing major pancreatic resections as well. With that, again, very happy to address or take any questions, and we'll hand it back to our chairperson, Dr. Nazihah. Thank you.
Thank you, Prof Weinberg. I think the CVC trick is universal. I also did that here. Okay.
I think I maybe even learned it from you.
All right. So Prof, we will invite any participants to ask the questions. You can either write in the chat box or you can raise your hand so we can unmute you. So we will give you a bit of time for question and answer for now, because we are actually already late by almost 10 minutes. Okay, but before any questions, since you have a very vast experience in quality improvement program, so I would like you to share with us regarding your experience. Do you think that the traditional models of anesthesia and surgical care are still valid now in 2021?
Look, I think the traditional models, will always be valid, because that's really caring for patients, but also caring for our staff, empowering our staff to look after patients. As Richard Branson always says, if you look after your staff, if you ensure that they professionally developed, don't worry about the patient. The staff will look after the patient. So I think the traditional principles of caring for patients, doing no harm, the ethical principles of benefiting, of adding value to patients are still there. But I think what's different now is we really are focusing on more effective ways to professionally develop our staff and have them much more engaged and embraced in taking on more advanced concepts by stepping out of that comfort zone of just using blood pressure in order to give a good anesthetic. Of course, we're all very experienced. The best monitor is really ourselves. If I could choose one monitor over any monitor, I would choose myself over any advanced monitor, because the anaesthetist, the clinician, the intensivist still puts things into context. So I think we shouldn't underestimate the ability and our skill. But I think we do have to move beyond that and step out of that paradigm and embrace emerging technology that allows us to make better decisions. We really need to develop not just our medical staff, but our nursing staff as well, our perioperative anesthesia nurses, our critical care nurses, but also our nurses on the ward, and empower them to also understand and appreciate the benefits of advanced monitoring for select patients undergoing high-risk surgery. We need to develop key champions, clinical leaders that inspire, that can embrace and teach and adopt this technology. We need clinical leaders in this area that can be responsible for teaching and educating and inspiring. And I think we have moved, we've made tremendous gains, and we've We've really taken giant footsteps over the last couple of years in just being more open-minded, more reflective, but still wanting the big studies to come out, still being measured, still questioning, always questioning, because there is no one correct way. There's many different ways, and that's really the art of anesthesia and of medicine, more than the science. But I think we need the science, we need the art, we need clinical leadership in this area, and we need to continue to look at ways to improve the lives of patients that we all privileged to care for.
Thank you, Prof. We have a questions from Dr. BJ. So Dr. BJ, you can continue with your questions.
Hello, Dr. Weinberg. I'm Dr. Vijay from Nepal. So, although I don't do liver transplant or liver surgeries on a routine basis, but still hemodynamics is something I'm really interested about, and I couldn't refrain from attending this meeting. So, thank you so much for the organizers, firstly. And I have two questions to put forward. First thing is, is there any role of, when you're talking about clinical thing about anesthesia, I would want to see whether there's any relevance about measuring capillary refilling time, CRT, to actually predict and to see whether the hemodynamics is good or not. First question, the relevance of CRT in hemodynamics, and especially in relevance to liver anesthesia and liver transplant and the surgeries that you do on a regular basis, because and also its relevance to lactate clearance, because liver is something which produces lactate, so maybe there could be some kind of variation in CRT and measuring its response to lactate clearance, firstly. And secondly, also, while in a country like ours where the resources are limited, what do you think to suggest that we can use the traditional monitoring methods or the minimum of the advanced methods you would suggest for routine surgeries? So two questions for me from my side. Thank you.
Wonderful, and what a wonderful country you come from. Austin Health feels very proud in helping set up your first liver transplant in Kathmandu 3 years ago, and I've been to your country 3 times. Wonderful medicine, wonderful people, and a really tremendous level of clinical engagement from the clinicians. So thank you for joining us today, and thank you for your comments. Your point about filling pressures is really important, and unfortunately we just don't have the technology to apply it clinically. I don't have much experience in that area at all. I'd love to embrace it more, because I think all these advanced hemodynamic numbers and metrics have a role to play. We don't understand how to apply them. We don't know enough about them, and they're very difficult to access. So I think you've made a very valid point. I don't have any experience, but theoretically, I think you've hit the nail on the head. We do need to continue to not only look at the macrocirculation, but we also need to pay much more attention now to the microcirculation and develop metrics that allow us to understand that the microcirculation is healthy, the glycocalyx is functioning well. And there are metrics of endothelial dysfunction. There's a lot of biomarkers that you can measure, but they're just not available for everyday use. They're very expensive. They require very specific assays. But I think over the next 5, 10, 15 years, the technology in measuring both the microcirculation, understanding these advanced metrics like you've mentioned, are really, really fundamentally important. And I think we've got a lot of work to do. As far as medicine has come over so many years, the more we learn, the more we appreciate we actually don't learn. So your point there is very, very valid, and I wish I had more knowledge. I feel inadequate to answer that justly and fairly. So, but it's a very good point, and thank you for raising it. Your second point is equally as important. How do we approach the inequity of providing advanced monitoring to countries that don't have the economic resources to purchase this technology? And I think it's a very, very important question. Firstly, we need to continue to invest in studies that demonstrate that this technology can improve the outcomes of patients, number one. We think that's, intuitively it makes more sense. If you've got more information, it should improve the outcomes. But we also need to work together with our health economic partners to better understand the cost benefits of this technology, because the hospital really doesn't put a measure on or doesn't emphasize enough the cost of complications. And we spend a lot of money, as I've shown you, on treating complications. And really, in our view, this technology can really be cost effective and cost beneficial in minimizing the number of complications. But again, we need key champions to really go in on a more granular basis to understand what the incidence of complications are for a healthcare system, to put a cost on those complications, and then to use business cases to motivate and justify and fight for the use of advanced monitors for patients that we look after. Now, this needs to be in partnership with industry. And as you can see from this type of forum, we do have industry that's extremely engaged, that is committed to helping us as clinicians, but more importantly, to improving the outcomes of patients. Edward Life Sciences is really exemplary in that regard. And for countries like Nepal, there are local supports available to get these devices into theatre, whether it's for research, whether it's to better assess the outcomes that it could make. And I really encourage you to reach out to your local representatives, whether it's Edward Life Sciences, who have sponsored the session, or other industries, because I don't think as clinicians we can do it alone. We have to now partner with industry. And partnership means working with industry that creates and designs and invents this technology, and then allows us to apply this technology in the clinical setting. I think now we've really have come a long way where we're moving towards better partnerships. And at the same time, we need to fight very strongly for having an equitable health system nationally, internationally as well, and supporting countries and hospitals that don't have access to this technology by allowing it and looking at business models and business cases where it could happen. So a huge challenge, and not just for countries like Nepal, Dr. BJ, it's countries like Australia as well. Many hospitals just say they don't have the resources to invest in this technology, yet have very high complications, and the cost of the complications are really just astounding. So a combination of working with industry, of clinical empowerment, of empowering our patients is working with patients, having our patients as our advocates now, to work with government agencies, with our hospital executive, to say this is really an acceptable standard that everyone deserves. It's not just for the ordinary patient. It's a right really for every patient having high risk surgery. We've got a lot more work to do in this regard, and together we should do it together with industry, with each other.
Thank you. Very good question, Dr. BJ. I think I also about to ask the same questions, because in Malaysia we also have this issue of cost. Okay, so we are very selective in using the advanced hemodynamic monitoring because of the cost. But I think if you compare with the complications, actually it's also cost higher cost compared to using the advanced monitoring itself. Okay, I think we allow one more questions because we are already ahead of time. I will allow Dr. Tepakon to ask a last questions. Okay.
Yes, thank you. I have one question to ask Professor. In case we have a patient with hypotensive and the SPV is low, that means the patient is not a fluid responder, and we have a value of low cardiac index and low DP by DT that indicate the patient is a cardiogenic cause. So my question is that what is the value of the DP by DT add on the value of the low cardiac index? In case we already have the low cardiac index value, what does the DP by DT add to the value of low cardiac index in interpreting And also the same question applied to if the question is vasoplegic, we can see the low SVRI and the low EADI. What does EADI add the information on the low SVRI? Thank you.
Now, look, it's an excellent question, and I think you are correct. So 2 questions. One, for many patients, it's an additional metric that allows us to better quantify that the problem may be cardiogenic. But I also think that the additional metrics are very important from a research point of view as well. And we're now starting to look at these additional parameters for clinical research. So I think there's a huge role to embrace these additional parameters for clinically, in the context of clinical medicine and everyday work, but also in the context of research. But I think you're 100% correct. I think we have to really go back to the basics first. Before we start mastering, the advanced metrics, we really have to be comfortable with a basic hemodynamic state. And as I showed you with my overview of approaching hemodynamics from a really basic point of view, DP over DT and dynamic elastance are important, but they don't replace the basic approach to hemodynamics. And if you are able to measure cardiac output or a stroke volume by default, you can really derive what your contractility is or maybe and what your systemic vascular resistance is. And at the end of the day, as I mentioned earlier, we still have to draw on our basic clinician skills. A lot of it is contextual. It's knowing, it's seeing, it's having a feel for what the hemodynamic problem is. But if we don't know what the hemodynamic state is, then we don't know what state we're treating. So the principles are, if you are comfortable using whatever information you need to better understand what the hemodynamic state is, you are 10 steps ahead of most of the world because you're already thinking in a much more critical way, and you're really thinking about what is wrong with a patient and what's the correct intervention for that patient. So in summary, I think the basic approach as I've presented is functional, it works well, it's very robust. The advanced metrics are good, they're nice, they're important, we should understand them and embrace them, but not at the expense of going back to good clinical skills.
Thank you very much, Prof Weinberg. I think we are already extended our session. I would like to thank Prof Weinberg for a very fruitful session today. I learned a lot today. I'm very honored to be the chairperson for today's session. Thank you very much. So in conclusion, I can see that major hepatobiliary and pancreatic surgery is associated with high risk complications, high complication rates. And the more complications you will have an increase in cost. So advanced hemodynamic monitoring is actually a critical tool because the liver resection actually possesses a high hemodynamic instability intraoperatively. So surgery and anesthesia must be aligned during different phases of a surgery. Hemodynamic goal must be patient specific and also procedure specific to individualized care. And advanced hemodynamic monitoring is only a tool, but it takes a clinician to take a correct action to actually correct the cause of hypotension. I think that's the end of our discussion for today. We would like you to give your feedback by scanning the QR code on the slides. I hope all of you had a fruitful session today, and thank you very much, Prof Weinberg, for sharing your knowledge and experience with us. It's really, really good session today.
Thank you very much, and I hope once COVID is behind us, for those of you that would like to come visit our hospital, and if anyone would like me to run a workshop for your individual hospitals, please reach out to your Edward Life Sciences representative. I'd be very happy to support you personally, for research or otherwise, or collaborate and really work together. And I also want to thank Dr. Nazihah for a wonderful amount of back-end work. There's been a lot of preparation for this, and I've seen firsthand how hard she has worked in facilitating this webinar for all of you today. So please join me in thanking Dr. Nazihah again for a wonderful effort and for putting this whole program together with the Edwards team. So thank you very much again.
Thank you very much.
Good night, everyone.
Okay. See you, Prof. I hope I can see you next